This is Betty Tai from NIDA. This is the seminar series we started with our data science group, and we try to invite inspiring speakers to speak to us and to advance our goal of starting using the big healthcare data and also the new technology in advancing our field. Today, we are so blessed with the presence of Dr. Susan Murphy. To many of you, she's not a stranger at all. She has been working with us in the CTM for the last many years. We all know her expertise in the adaptive design, but only recently at a meeting I heard her talking about the mobile technology. The information just blew me away. I really enjoyed so much. So I requested her presence to talk in this seminar. Am I hearing an echo? Do you hear an echo?
Sorry. Hello.
Oh. Okay.
Hello. Good afternoon.
Susan, can you hear us?
I hear you. I hear you just fine.
Okay. All right. In addition to Dr. Murphy as a very distinguished scientist of NIDA and the NIDA's grantee, she receives research funding from many, many other resources. And most notably, she is also the recipient of the MacArthur Genius Award. So we're very much looking forward to hear from you. Susan, just please take the microphone and start. Thank you.
Okay, thank you, Betty. Thank you for the introduction. It's a pleasure.
Thanks a lot. Actually, Susan, thanks a lot because I was late. But thanks very much for doing this.
Yes, I appreciate the opportunity. So I'll go ahead and start now. I appreciate the opportunity to be here with all of you today. We're going to talk about a particular kind of trial design, a way to collect data that's useful in mobile health. And in particular, we'll focus on two different trials. They're HeartSteps and a smoking cessation trial. But we're also working, our team is also working on trials in substance abuse as well as alcoholism. So what I'll start with is a discussion of this notion of the just-in-time adaptive intervention. This is not a randomized trial design. This is a treatment design, akin to a treatment protocol. And by going through that, by thinking about the elements in these interventions, we can think about how we can improve them. So just-in-time adaptive interventions. The idea here is to be able to adapt the intervention to the individual, take advantage of heterogeneity, between-person heterogeneity in response to interventions, as well as within-person heterogeneity in response. And what's special in the mobile health setting is that we can aspire to deliver supportive interventions when they're needed, say at 2 a.m. in the middle of the night, or wherever they're needed. So here's a really simplistic example, but it will help me identify the elements of these just-in-time adaptive interventions. So this was a study from 2013, and it was about how to reduce sedentary behavior by office workers. I don't know about all of you, but this is an intervention that I could use myself. And what it does is it software on the phone monitors your computer activity via your mouse and your keyboard. And if you stay continuously active for 30 minutes, then you get a text message on your phone that asks you to go to a link where it gives you suggestions about how you might reduce your sedentary behavior, like stand up and walk around and so on. This is a just-in-time adaptive intervention. So what are the elements? And we're going to see these elements in this little simple example. There's a distal outcome. Of course, this is the outcome that we care about clinically or from a public health perspective. I'll discuss that more further in the next slides, but in the case of our simple outcome, our simple study for sedentary office workers, this could be greater productivity or reduced health costs. There's also a proximal response. These are responses that are in the near time. So here the message that the person receives on their phone is to prompt them to stand up, maybe walk around. That's the response we're looking for. Tailoring variables. Tailoring variables they help you decide when to provide a message. And we saw that in this simple example before because the computer software monitors your keyboard activity and your mouse activity. So that's the tailoring variable, the mouse activity, the keyboard activity. I'm going to go first to the intervention options and then return back to decision rules. Intervention options here, this is sending the text message and providing suggestions about how you can reduce your sedentary behavior. Or it may be another possible intervention option is to not do anything. Actually, in this particular example, there were 3 different strategies that were used when a message was sent. So they could be, they're also intervention options. The decision rule here in our really simple example, there's only one decision rule, and it says, if 30 minutes of uninterrupted computer activity occurs, then deliver a message to encourage walking. And this adaptation is triggered at decision time. So you can imagine that the software on the computer is monitoring every, say, 30 seconds to keep track of your mouse activity and your keyboard activity. And once you hit that 30-minute mark, that's when when a intervention is sent. Okay, next slide. So with the just-in-time adaptive intervention, which we've seen this simple example of, the proximal response, I said this already, but it's important to realize this is really an in-the-moment impact. You're trying to help that individual at that moment in time. And of course, the goal is longer term to have an impact on the distal outcome. The decision times are really real time, and we're going to see examples of this as we go through on the next slides. In fact, what I'm going to do is I'm going to go through each one of these elements and discuss them in the context of the 2 studies, HeartSteps and the smoking cessation study. So first I'll introduce the 2 studies, and then I'll discuss each of these elements. So the MD2K smoking cessation study, this is a study that's going to go into the field in the next month. And in this study, it's a 14-day study. Each individual is wearing a chest band, which is collecting a variety of sensor streams, as well as a Microsoft band on both wrists. And the sensor streams are being used to create real-time classifications of physiological stress. We're also collecting craving by self-report and burden as well. There's supportive stress regulation interventions. They're mindfulness interventions. They're always on the phone. They're available on the phone 24 hours a day, 7 days a week. The issue is, though, often at the time an individual might most need to practice one of these self-regulation exercises, they may not be thinking about it. And so the question we want to address by collecting this data is, in what settings, that is, what tailoring variables should we use to have the wristband vibrate and then provide a reminder to practice one of those stress regulation exercises that resides on the phone. So that's the smoking cessation coach. As I said, it will go into the field in April. HeartSteps, this is a set of 3 studies. We finished the first study. We just finished the first study. And here we have a wearable band on the individual's wrist, of course, and then we're also collecting a variety of sensor streams from the phone. As you can see, there's a measure of how busy the person's calendar is, their current location, if they're home, at work, the weather, and so on. And a very similar question, we want to address a very similar question as we go to construct a just-in-time adaptive intervention, and that is, in what settings, what context, should the smartphone ping and deliver ideas, tailored activity ideas to the participant? Okay, so now I'm going to go through each of one of those elements of a just-in-time adaptive intervention, and I'll refer back to HeartSteps and the smoking cessation study to provide clarity. So the distal outcome, that was the first element, and as I mentioned earlier, the goal, we always have a goal, a clinical or a public health goal, and this is what the distal outcome is concerned with, that goal. So preventing relapse to substance abuse or substance use cessation, maintaining increased activity level, maintaining adherence to medication, and so on. These are the types of distal outcomes you might see in this setting. In the case of HeartSteps, this is a 42-day study, and the distal outcome was operationalized as activity step count over the study duration. The two subsequent studies in HeartSteps are of longer duration, and in particular, the last one will have a cardiovascular outcome. In the MD2K smoking cessation study, the distal outcome is time to relapse. Decision times. Okay, so usually we see them come in one of two flavors. They're either intervals in time, every so many seconds, every 5 seconds, or every 2 minutes, so on. Or they're when a user requests help on the phone. There's often people want to have a button that the person, the user, the participant can click on, and then, for example, a text message might go to a sponsor and request help. So I'm going to focus on the former, that is the regular intervals in time. This occurs pretty much throughout all of the studies I've seen. And the natural question to ask is, at what frequency should these decision times be? And the frequency is guided by the dynamics of the tailoring variables that you have in mind. And we're going to see this shortly on the two examples. And the frequency of the decision times is also guided by what kind of intervention effect you're looking. Are you trying to really help someone in the next 30 minutes? Hopefully they'll learn from that, but your immediate impact, you want an immediate impact on the individual, or are you looking for effect over the next day? So let's think of HeartSteps. This is this activity coach. Is for sedentary people. And here we had access to a large amount of data by the business that produces the wearable for the wrist. This is Jawbone. And when you look at this data, you see that if people are active at all, there tends to be 5 different times when they're generally active. Before they go to work, around mid-morning, around mid-afternoon, right when they're returning from work, and then in the evening. So this is approximately every 2 to 2.5 hours. So this is the right time points at which we might be able to help someone be active. In the case of the smoking cessation study, here we're really interested in how stress is known to be a risk factor for relapse to smoking, relapse to most addictions, in fact. And we didn't have a deeper understanding of the dynamics of stress. So in the case of this smoking cessation study, we have a decision time every minute because we're going to have a measure of stress every single minute. That doesn't mean we're going to treat someone every single minute. Most of the time the decision will be not to bother the person at all.
But how do you determine that that person is stressed in a given minute?
Yeah, that's cool. So in the case of the smoking cessation study, this is a proof of concept study because each participant is wearing a chest band the chest band, as well as bands on each wrist, Microsoft bands on each wrist. And the chest band is looking at, it's collecting, it's 35 different sensor streams, one of which is like the peak-to-peak in the heart rate variability, and others, and then we have a classifier that takes the different sensor streams and gives us a classification at each minute, stressed, not stressed. Now, there'll be some minutes where we won't get a classification because this is physiological stress. There'll be some minutes where we won't get that classification because the individual will be physically active. And then you can't, our method does not discern stress from physical activity. So even though at those minutes, you may have a decision time, but you'll automatically choose not to do anything. That is at minutes where we can't get a good measure of stress. Classify it, yes, no. We won't bother the individual. Okay. So now we're on proximal responses. Now, remember the interventions, the idea is the intervention will impact the proximal response, and then that will lead to better distal outcomes, the clinical outcomes, the health policy type outcomes. So if you're a behavioral scientist, this is a natural way to think in terms of mediators. And so first, short-term targeted behavior might be a natural example of a mediator. So in the case of the physical activity, HeartSteps physical activity over the next 30 minutes, that would be a perfect proximal response, because if we can't help you improve your physical activity after we give you a suggestion, it's not clear we'll be able to do it in general. Also, another type of mediator, it could be short-term risk, and this is where the smoking cessation study comes in, because here the goal of these interventions that are on the phone, it is about helping you manage your stress. So here we'll be looking at stress, and stress is thought to be a mediator on the pathway to relapse to smoking. Another really interesting mediator that I don't think we've spent enough time on, but the interest in it is incredibly high, and that is we need to also think about, we'll also have interventions that are aimed at helping you stay engaged so that we can help you over the longer term. And here, the proximal responses should be related to engagement or intervention burden. And I'm going to show you an example of that shortly. So in terms of HeartSteps, one, I already mentioned this, a proximal response would be step count, say over the next hour, next 30 minutes. In the smoking cessation study, it might be the fraction of times you're classified as stress over the next so many minutes. I already mentioned this about intervention options. The idea is the intervention options are often, not always, but often formulated to have to impact the proximal responses, those mediators, and then improve the distal outcome. Of course, we do hope there's going to be a learning effect, that gradually someone will self-actuate. That's part of this as well. So I list a whole variety of intervention options. If you're familiar with mobile health, you'll know that the variety of interventions options is much wider than one might think. And there's behavioral strategies, say alternative behaviors when you're feeling craving. There's cognitive strategies, how to reframe a lapse. There's self-monitoring, where you look, for example, at your behaviors, your eating habits, enhancing social support, and so on. And of course, how do you deliver that intervention option? That's really important, and the human-computer interaction guides spend a great deal of time on how you deliver the option so that it will be received and acted upon. And then lastly, there's the provide nothing option. So in the case of HeartSteps, I'm going to focus on whether or not to provide a tailored activity recommendation. By the way, these activity recommendations are tailored to the weather, location, time of day, whether you're at home or work. I'll focus on yes, no, but it actually turns out there's two types of activity recommendations in HeartSteps. In the smoking cessation study, I'm focusing here on yes, no, should you provide a reminder or not. And here also there's 3 different kinds of reminders because we have 3 different stress regulation apps that are on the phone that the individual can access. But in general here, I'm speaking about yes, no. And one of the reasons why I'm focusing on this is constantly providing interventions does impose burden and habituation. I think there's going to be more signal in the yes-no decision. Okay, here's an example from HeartSteps. This will help make things clearer. As I said, it's yes, no, should we provide an activity suggestion or not? This activity suggestion came in the middle of the morning when I was at work. And it comes down, the phone pings, it lights up, lock screen lights up, and then on my notification bar, I get this little notification. And it gives me an idea, I was at work, why don't you go outside and walk until you see, for example, a squirrel. Now, I have 3 ways that I can wipe off this notification. I can press thumbs down. I didn't like the message. Wasn't very useful. I can press thumbs up. You see the thumbs up? Let me see if I can.
No, we can see that.
You can see it? Good.
Yeah, we can
and then
see that.
I could also press, that thumbs up is if I like the message. So these are, in some sense, measures of engagement or utility, user perceived utility. And then in the middle, there's this little buzz thing. If I press that, a lock screen comes down, and I can turn off the intervention for 8, 12 hours. And that turns out to be really useful if you're going into an NIH review committee meeting. So, okay, so we're still going through those elements. Tailoring variables or moderators. They tell us which intervention is best, when, where, and for whom. Often they are past proximal responses like, is it a good idea to provide a message when you're currently stressed? They could be risk and protective factors. They could be related to adherence, whether or not you're showing engagement or not. This might determine whether or not it's worthwhile to provide an intervention. So in the case of HeartSteps, I provide a number of potential tailoring variables we're interested in. So how active were you in the prior 30 minutes to a decision time? If you were very active, it could be that providing an activity message won't be as impactful, and so on. In the smoking cessation study, a number of people on the team are hypothesizing that the reminders to access the mindfulness interventions on the phone are going to be most effective if you're currently classified as being stressed. That's a hypothesis. So a potential tailoring variable. Decision rules. Okay, so as we saw in our little example with sedentary office workers, decision rules are used to link the tailoring variables, like your past, prior 30 minutes activity, to whether or not we should provide an activity message at a decision time. There's usually, any given just-in-time adaptive intervention generally includes a number of different decision rules. You may have some decision rules that are focused on maintaining engagement in the intervention, and whereas others may have a more therapeutic role. And the way in which we develop decision rules is, it's in general, the way we develop treatment algorithms, we guide that by our theory, behavioral, biological theory, cognitive science theory, as well as clinical experience and data. And what we're going to talk about next is how we can collect data to guide the development of these decision rules. Of course, in both HeartSteps and in the smoking cessation study, that's our goal, is to develop decision rules. Okay, here's a summary of the elements that we just discussed. We discussed distal outcomes, proximal response. This is what we're trying to impact in the moment. The intervention options, how we're going to impact those proximal responses and then achieve our distal goal. Tailoring variables, when and where we're going to provide intervention support. And the decision points, that's the times at which we would potentially provide an intervention. And the rules linking these together. Okay, we're going to go on to the micro-randomized trial. So what is a micro-randomized trial? These are trials where, oh, I shouldn't put actions. This should be intervention options instead of actions. It's randomized between intervention options at the decision times. So let me just think about HeartSteps. This is a 42-day study. We have a decision time every 2 to 2.5 hours. It's 5 times a day. So 5 times a day, 42 days, 210. So in HeartSteps, we're talking about 210. Every person is randomized around 210 times. These are what we would call full factorial. They're sequential full factorial designs. If you're familiar with full factorial designs or factorial designs of any kind, you may be familiar with Linda Collins' work. Full factorial designs are used for building interventions, such as a just-in-time adaptive intervention. Full factorial designs are not used for evaluating a completed intervention, a treatment package, or a completed just-in-time adaptive intervention. They're really used to design one, to form, to put together all the parts of your intervention in the best way. So that's what we're talking about here. It's how we collect data to develop a just-in-time adaptive intervention. And generally in full factorial studies, when you try and figure out how many participants you should recruit into your study, you do this in order to, that is, you size the study to detect whether there's a signal at all of your interventions. And we call that the main effects. In factorial designs, they're called main effects. It turns out micro-randomized trials can be viewed as an extension of 2 types of trial designs that we see. One is called A/B testing. This is used throughout industry, particularly in with web advertisements. These are generally it's between person randomization of where you're going to place the web, say on the screen. And then single case designs, we see this in behavioral psychology. This is where these are generally within person randomized trials. And in the micro-randomized trial, we're going to both have randomization of our intervention options both within a person as well as across people. So what are the elements of a micro-randomized trial? Of course, you're going to have randomization because we're talking about a trial. You record your outcomes, the distal outcomes, the proximal response. You record your observations. So a lot of these observations are going to be from wearable sensors. Some will be from self-report as well. Some will be those thumbs up, thumbs downs that we saw before. You randomize during the trial, each participant is randomized among the intervention options at each decision time. And then after the trial is over, you assess, did our interventions impact our proximal response? What's their impact? You assess moderation. Was the impact of our intervention greater in some settings as opposed to others? And you can construct preliminary decision rules to be vetted by your scientific team. So I want to talk about why micro-randomization. This is when I give talks to computer scientists, I often discuss this at some length. I think this is a very different audience. You're quite accustomed to randomization, but it's really important to remember why we do randomization. And randomization allows us to disentangle why someone received an intervention from the effect of the intervention. So we know that in mobile health, we have access to vast amounts of data where we can see whenever someone accessed an intervention that's residing on their smartphone, for example. Then we can look at their behavior after they access that intervention. And we would like to use that data to assess whether or not the accessing of the intervention had any impact on the person's behavior subsequent to that following that access. The issue here, and these are called observational studies, as you know, the issue is it's very hard to disentangle why someone accessed that intervention from their behavior following it. It could be just because they're a very motivated person, so they both access the intervention, and because they're very motivated, they're doing all kinds of other things, so they also have good behaviors. So randomization breaks that link and allows us to directly assess the effect of the intervention on the subsequent behavior. So HeartSteps. Let's see how it works with HeartSteps. So we're focusing on whether or not to provide a tailored activity recommendation at each of those 5 decision times per day, 42 days. In the case of HeartSteps, we wanted to ensure that we had around 2 intervention messages per day. We didn't want to have too many because then people would start to really habituate or get aggravated. So that the average of 2 a day led to a randomization probability of 2/5. Yes, with probability 2/5, they'll get a recommendation at a decision time, one of the 5 decision times, otherwise not. So a first question to address, since we're talking about a factorial design, is the main effect, and that is essentially, do the intervention options, does providing a tailored activity message impact your activity over the subsequent 30 minutes an hour? Testing for a signal. Okay, so this is interesting. These next 2 slides I find very interesting. That may be just because I'm a statistician, so please forgive me if you don't find it as interesting as I do. So we're talking about factorial designs here. We're talking about the effect of an intervention that we provide repeatedly over time. We have to then acknowledge that the effect of that intervention may change with time. In particular, given the reality that these interventions are being provided in the real time, in the life of in an ecological fashion, in the real life of the individual, they can be burdensome, and habituation can occur. That by habituation, I mean that people begin to, they don't even see the message. So as a result, the effect of the intervention may vary with time. It may begin to, in fact, I'm concerned mostly with it dissipating with time. So we're going to have time-varying main effects for our, in this study. The other issue that comes up, and this issue I didn't really want to deal with, and I think many of us don't want to deal with it, but it's occurring in almost every mobile health study I see, and often we just don't mention it. But it's absolutely critical to understanding how to interpret the effects that we do see. And that's the issue of availability. Interventions can only be delivered at a decision time if an individual is available. So let's go back to HeartSteps, this activity study. We have a classifier on the phone, and it tells us whether or not the person is moving very fast, so they could potentially be driving, or they're walking, or they're currently sedentary. If they could potentially be driving, we consider them unavailable. We don't want to interrupt them, distract them potentially from their driving. So in that case, we will not provide an intervention at a decision time if they're currently driving. Another way someone can be unavailable in the HeartSteps study is if the classifier currently says that they're walking. We don't want to ping them, interrupt them, and suggest they go for a walk if they're currently walking. Again, they're unavailable. And the last way in the HeartSteps study the individual can be unavailable for intervention is if they have currently turned it off. So when I go to that NIH review committee meeting, I turn off that intervention and it will not ping me. I am not available for being intervened on. In the smoking cessation study, we have similar considerations. People can turn off the intervention for privacy in that particular study. So when we talk about the effect of the intervention on the proximal response, on the near time response, we're talking about a comparison of available individuals who are assigned an activity recommendation versus available individuals who are not assigned an activity recommendation. This is still a causal contrast. It's among a subpopulation of individuals who are currently available. For both the availability reason as well as the burden and habituation, you end up with these time-varying effects. I'm going to go through this in greater detail on the next slide. So let's think about the main effect of a tailored activity recommendation. So I'll call it beta. This is just the comparison of getting the activity message on your subsequent activity versus not getting the activity message on your subsequent activity. So, and that can occur, remember in HeartSteps, up to 5 times a day. You'll either won't get a message or you will get a message. It's randomized. 5 times a day, 42 days, 210 days, 210 times. So let's look at this little schematic. It's kind of, it's gross, but it'll allow me to be clear about the ideas. Across the horizontal axis, we have our 210 decision times. Across the vertical axis, we have the standardized effect of providing an intervention, an activity intervention. Now we know that the effect probably will not have this nice smooth curve. In fact, there's probably diurnal trends. Some people will be more likely to be responsive in the morning versus the evening or when they're at home and so on. So this is an average here. But nonetheless, at the very beginning of the study, people are a little confused. They don't know what to make of these activity suggestions. There might not be much of an effect. So that's the reason why at decision time point 0, you don't see an effect. But then as time goes on, people begin to try out these activity suggestions when they get them. And then they're more active when they get a suggestion versus when they're not. Unfortunately, I'm concerned that over time, as time goes on, they habituate, they start to ignore the messages, and the effect dissipates. This is a potential kind of gross trend. There's another reason why this trend may vary with time. And that's because at each decision time, we're assessing the effect of that activity message on the people who are available. So let's think about the people will not be available for the activity message if they're currently walking. These people have really engaged in the intervention. They're learning how to be active as the study progresses. So you can imagine someone who really starts to engage in the intervention. They're walking at most of these 5 times a day. They're not going to be available in the study at later decision times. And so they won't be we're not looking at the effect of the intervention among them. They've drank the Kool-Aid. They're already in, and so on. So that's another reason why the main effect of the intervention, may vary with time, because the population among whom we're assessing the effect is varying with time. As I said, this is occurring throughout mobile health. Often we just don't discuss it. So I showed you this slide before. We're going to look at how can you test for the main effects. Do we ever have an effect? Do we ever get a signal? We're going to size our study. That is, we're going to determine the number of participants so that we can detect if we have a signal. Capital T here in the case of HeartSteps is 210. In the case of the smoking cessation study, it's going to be in the thousands. So I'm thinking of HeartSteps here, so I do have we're looking at our null hypothesis of no effect of the intervention. So is there an effect at decision time 1? Is there an effect at decision time 2? All the way up to, is there an effect of the intervention at decision time 210? There's no effect, of course, if that is 0. So this is overwhelming. It's an awful lot of things we're trying to test, 210. And so how do we deal with this? And what we do is we use ideas. They're pervasive throughout of all of big data, for example, and that is we focus our attention on lower dimensional alternatives. And I'm really concerned in many of these studies that habituation is going to cause the effect to dissipate with time. It's not necessarily going to be a quadratic effect, but I'm very concerned about it dissipating over time. So one way is to determine the sample size to ensure that we detect anything that's approximately different from 0 in a quadratic direction, so allowing there to be a dissipation with time. If I do that, I go from 210 things I have to test to only 3, an intercept, a linear term, and a quadratic term. Turns out this idea is used throughout toxicology in bench research, but it can be used here as well. This same idea of having a simple alternative. So the minute we specify we're going to focus our alternative on a simple alternative. Now, the real alternative, hopefully it will be different from 0, but it may not be quadratic. But by focusing the test statistic on that simple alternative, we can still detect non-quadratic alternatives. We'll just project to a quadratic. What does that do for us? It does a really interesting thing, and it takes advantage of the fact that we have a combination of A/B testing and single case studies. That is, we use both between-person contrast and response, when someone got a message, when they didn't, versus when they didn't, as well as within-person responses. So one person got a message, one person didn't. Compare those responses. You look at just one person, at times they got the message versus times they didn't. The end result is the required number of participants tends to be small if you're looking at these types of momentary effects. The test statistic will develop. It's going to be the basis. It is the basis of the sample size calculator that we have. It uses a generalization of linear regression. So it's very simple. It's something many behavioral scientists are familiar with. So as you know, when you go to size a study, when you go to determine the number of participants, you have to decide what kind of effect size you're going to aim to detect. And that's what we're going to discuss on the next slide. So we specify a variety of standardized main effects in this particular example. We'll specify what kind of effect do you think you'll get the very first day you provide this intervention. Then we'll ask, well, what kind of effect you might get on average across the duration of the trial. And then we'll ask, these are all standardized effects, at what day do you think you're going to get your maximal effect, and then from then on it may dissipate. I'll show you an example with HeartSteps. So with HeartSteps, we decided we would be very conservative, so we said the initial main effect will be, we won't have any effect on the first day. People will be too confused. And we decided that about midway through the study would be the day at which we might get a maximal main effect. It's turning out actually the real data is where it's a lot longer. The maximal main effect is occurring later in the study. And then I'm going to show you a slide on the next slide. I'll give you a variety of average standardized main effects to look at, along with the sample size. So here we're looking for power equal 0.8, power to detect a difference from the null of no effect at all. We're having a type 1 error rate of 0.05. That is the error rate of detecting something when there's nothing there. We have I'm going to give you two sample sizes. One, if on average an individual is 70% of the time available. Remember, in the HeartSteps study, a person is not available if they're currently walking, they might be currently driving, or if they've turned off the intervention. So we have both on average 70% availability or 50% availability, and you see the two sample sizes. You also see the standardized effects on the left-hand side. Now, I want to be real upfront with people about this. At first, when you first see this, you think, at least I thought, this is what I thought. I thought, whoa, these sample sizes are small, because that standardized effect size, 0.1, I mean, that's half of Cohen's small effect size of 0.2. So it sounds like we have really small effect sizes, and we're able to detect them with really small amounts of data. But I think we need to step back and think a little bit. We don't know in mobile health what constitutes, for example, a large, medium, and small effect size when we're talking about effects occurring in the moment. So it could be that we'll discover, we're part of a number of trials of this type, and it could be that if you talk to me a year from now, I'll tell you that 0.06, an average standardized main effect of 0.06, is pretty big. But I don't know at this time. I just want to make some comments when you go to, by the way, with HeartSteps, we ended up going for 40 people. Some people dropped out, and we ended up with 37. So we were in this last row here. So here's some comments about if you're planning a micro-randomized trial. We're involved with multiple trials of this type, and we want to help people ascertain a good number of subjects so they can really do good science. So first of all, you want to be conservative. This is the kind of thing statisticians always tell people. You want to underestimate the amount of time participants will be available. So for example, if you think participants will be available 70% of the time, and in reality they're only available 50% of the time, then you won't recruit enough people. You also, as we all know, you want to underestimate the standardized effect size. So if you think the standardized effect size is 0.2, but in reality it's 0.1, you're going to not recruit enough people. When we developed the sample size calculator, we did a whole variety of different types of tests of this calculator. For example, we assumed that the real effect of the intervention varied by the time of the day or the day of the week. And we had a good bit of power to detect the main effect, even though the true effect was not quadratic. It was robust also to interactions, which is typical with factorial designs. I just want to point out that many of secondary analyses, of course, and we're working right now on the secondary data analyses, they concern in what they directly address that question: in what context is it most useful to provide the intervention? Should you provide the mindfulness intervention when the person is currently classified as stressed? Last slide. I want to go through when these trials are useful and when they're not. It's very easy to go down the path in which they might not be useful. So suppose you're studying a setting in which is not very, doesn't occur very often. For example, you're interested in suicide, and you want to learn what's the best type of alert to send to, say, a spouse or a clinic to prevent a suicide attempt. Well, this is not a good setting in which to use micro-randomized trials. Suicide attempts just don't occur that much. Another setting, a very similar setting, is in psychosis. If you're working with people who have schizophrenia and they have periods where they become psychotic, they don't become psychotic frequently enough to learn using a micro-randomized trial what's the best thing to do at that time. A useful setting is when the malleable, the circumstances that you can influence change rapidly. So stress, which is a big craving, and stress are both strong determinants of people's relapse, and these do change rapidly. Adherence as well to medications, that changes from day to day or even within a day, and so on. Another setting in which micro-randomized trials are not useful is you can't assess the impact of your intervention, even though your intervention was designed to impact that person in that moment. So you can't feasibly sense that. So with the smoking, the activity study, we have their step count from their wristband over the 30 minutes, the hour following a decision time. So we can assess that proximal response. But there are settings in which our sensor technology has not gotten to the point where we can really assess the proximal response in real time. For example, part of the MD2K study group that I'm involved with they're working on real-time predictions of craving minute by minute. Once we can get good proximal measures of craving minute by minute without pinging people constantly for self-report, then we could use that as a proximal response. Okay, I just want to thank all my collaborators. We have grad students that do all the work. We have undergraduates that program these apps and put them into the field. You'll see Peja Klasnja, he's going to speak to this group later on. Tewari is a computer science, and Billy Nahum Shani, she's behavioral science. You also see a link to a beta version of the sample size calculator should you like to check that out. Thanks for this opportunity.
Thanks a lot.
You're welcome.
Susan, I see there's a couple more minutes. Can we ask you a question?
Oh, of course.
I'll start. Everybody else can follow up. Every time when people talk about these mobile devices, inevitably people will ask how to protect the privacy issue. Do you want to share your view?
Right. So, of course, as you can imagine, the transmission of data has to be HIPAA compliant. There's a lot of constraints in that's already, that starts from the get-go. It has to be HIPAA compliant. Okay, that's the first thing. The second thing is in some studies, for example, the smoking cessation study, we allow people to say, I want some privacy right now, and turn off the tracking. So you can't even track them. And I can imagine in addiction studies this could be somewhat problematic. There's some issues here because it could be that the reason why someone wants privacy is because they're going to go and snort cocaine, for example. But that isn't, if we want to help people, for example, like in recovery support, over long periods of time, over years of which they struggle to stay abstinent, we do have to have a way for them to have some privacy. The other issue is in terms of constant tracking the traces of an individual as they go through their daily life. So one thing we're doing in the MD2K study is that we have we have layered access to the data. So the data which involves the actual trace of the individual through the day, almost no one has access to that. For example, I won't have access to that. But I will have access to whether they're at home or at work. I don't know where home is and where work is, but I'll know that at this time they were at home. At this time they were at work. I may know at this time they were at the bar that they usually go to, that sort of thing. So that's another way to protect the privacy of the individual is to really strongly restrict the traces, the actual trace of the individual through time. That's my current thoughts right now. Those are my current thoughts.
Thank you. Anyone else have a question? Please, yes.
Susan, could you clarify? It sounds like you can validate when people do the recommended intervention. You can look and see what their activity level is or if they've accessed an app on the phone.
That's right.
And you're tailoring when that recommendation is made. Are you also collecting data on what they actually act on and tailoring the kind of intervention that's recommended?
Right. So in all of these settings, for example, the activity study, I'm not sure if I understand you correctly. I'm going to try to answer you, and then you can correct me. In the activity study, those messages are tailored. Otherwise, they aggravate the participants too much. So they're tailored. Like, we won't give you a message about that concerns physical activity outside if the weather's really bad. We just won't do that. We won't give you a message to do jumping jacks if you're currently at work. So there is already some tailoring going on. We're not experimenting with that tailoring in the sense that we're not randomizing that aspect of tailoring. However, we did randomize whether the message would be a message which promoted, which was just moving, like rolling your arms, versus actual going out and having physical activity. We did randomize that within so in actuality, if someone was randomized to an activity message, then they were further randomized to whether that activity message was anti-sedentary behavior versus physical activity. So you see this a good bit. I think, yeah.
Collect data from the person over time as to, it sounds, that's great, you're tailoring based on weather, et cetera, but which, independent of those things, which recommendations individuals most respond to over time for that particular individual?
Right. Well, we'll know the change in behavior before versus after. And if most of the time, all of these messages, they're in large buckets of messages, so very rarely would someone get the same message twice. But they might get a physical activity message twice. They're different kinds of messages, but they're both physical activity messages. And we can look, did they tend to respond in general, say, for example, to physical activity message provided in the morning? Or did they tend to respond to more to physical activity messages in the evening after work? We can look at questions like that. We can look at what was their step count when they got a message that was more about reducing sedentary behavior as opposed to a message that was about physical activity. That's a very interesting question, actually, but anyway. So we can look at the context. We can look at, we can ask them at night in the physical activity study. We also ask them a number of things like what messages they found they remembered getting. We find out what messages they remembered getting, and then we get some indication of how useful they found the messages. That's in addition to the thumbs up, thumbs down.
Anybody online has a question for Susan? So if not, Susan, thank you so much. And we appreciate your getting on giving us this seminar, and we hope to see you at our future meetings.
Yes, it was a pleasure. Thanks, Patty. Appreciate it.
Sure. One last question, just, you don't have to answer. Since we are so much interested in monitoring the opioid overdose, and your tool seems to be able to measure a lot of the physiological factors, I wonder if that can be used to monitor the overdose and deliver intervention, on time, real time. So
yeah, I wonder, Betty, if that's similar to the suicide problem, where it doesn't happen enough, so you wouldn't want to do micro-randomization. But however, I can imagine some sort of monitoring of physiological stress or physiological responses, right? Because if you do take drugs, well, some drugs, they will make your heart rate race, and so that would be a way of detecting drug use that didn't require you to get self-report.
right.
Interesting. I mean, not all drugs make your heart race, right?
Yeah.
Other drugs may make you very may slow down your heart rate.
Yeah, like opioids. Yes, exactly.
Right. So it just depends. But
Yeah.
you could use that for some sort of real-time monitoring. You know, the chest band, this is a proof of concept type setting. If things work out, the idea is that we're gonna be able to micro-engineer that, and we'll have the wearables. You can sew them into undershirts and things of that type, or use also, and in combination with the sensor streams from the bands on your wrists, they could be very useful. So.
Yeah, but if it's respiratory suppression, can these tools measuring the CO2, exhaled CO2 level, or I don't know. I'm just throwing this question. I'm pretty sure if you
I think that requires participant engagement. The participants do something for you to get this.
Yeah.
And that's that's another reason why I think we as a community really need to spend a good bit of our time on engagement interventions.
Right. Totally. All right. Thank you so much. Talk to you soon. Hope to see you soon.
Bye-bye.
All right. Bye-bye.